क्या लेंगे आप? चाय कॉफी? कुछ चाहिए तो बताओ.
Is Tulane University. Which state is that in?
I can ask. Doctor Paul? Is he there? He was not. He's left us there. Tulane,
He said he's in New Orleans.
yeah, I think it's New Orleans.
That's New Orleans.
It's New Orleans. Yeah.
She's a different one. Yeah. Yeah. I'll introduce her.
Yeah. This the other factors.
Almost time.
4 minutes. Getting some online questions.
Right. Probably that.
So mostly these things should start on time.
That's just there.
They are already seeing you. So we just need to be audio.
Close the door.
Yeah.
Are we going to say welcome to the program? What is the program called? Not sure.
Hello. Yeah.
I think there is no program.
This is live discussion. This live. So we have 3 minutes. Yeah. Okay.
Let's go back to Lynn. There is
Doctor, where's Tulane University? It's in New Orleans only?
In New Orleans, yes.
And you pronounce it?
Tulane.
Tulane, okay.
Yeah.
how many questions are there?
Huh?
How many questions are there?
There are, I think, three, four. Check out.
The slides will show, no?
Yeah, he put his slides on after you. Then he put his slides.
Then pass on over to
Yeah. We have 2 minutes to go.
Okay.
I think we can start.
Good evening, friends. All the doctors who have joined in from India. I'm Dr. Jamshed Dalal, cardiologist from Kokilabein Hospital, Ambani, Kokilabein Ambani Hospital from Mumbai. With me today, co-chairing is Dr. Shaileja Sheikh. She is the well-known endocrinologist from Saifi Hospital. So welcome, Dr. Sheikh. And of course, the main speaker for today is Dr. Paul Welton. Dr. Welton is at the Tulane University in New Orleans, from which he is going to give his talk today. Many of you are already well aware that he's been a part of many trials, such as the All-Hat and the Sprint, of which we are all very well aware of. He is the chair of the ACC-AHA 2017 guidelines. So what we will do today is to have his presentation about the guidelines, and then Dr. Sheikh and I will give our comments. And then after that, we will take your questions, and we'll have a very fruitful 1-hour discussion today. So thank you very much, Dr. Paul Welton, for being a part and teaching us all over India. There are thousands of doctors who joined in, and you may be surprised that even before you started your talk, I already started getting questions. So I think we're going to have a lot of question answers at the end. So welcome, Dr. Welton, and please start with your talk.
Well, good evening, everyone. Nice to be with you, Dr. Dalal and Dr. Sheikh, and all my colleagues and friends in India. And I think now, let me just make sure I know what I'm to do here. So what do I press? Oh, share screen, right? And go to this one. Now, that working okay? Slides coming up? I hope you can hear me, because I can't hear you.
Yes, we can hear you well, thank you.
Okay, perfect. Well, lovely to be with you. I will give a brief presentation on the guidelines. I don't have any conflicts of interest, but as you heard, I have a number of disclosures regarding my roles, just so everyone is aware. So let me see if I can get to the next slide. I don't seem to be able to advance the slides here. I'm sorry,
Doctor, you just need to press the arrows. The arrow on your keypad.
I'm pressing the arrow, but it's not advancing the slide.
Okay.
Yeah, the slide is not advancing. Can you advance it from your end? Yeah, it's not responding to the arrows.
We're just trying from you.
Thank you. This is always the hard part.
Yeah, as difficult as getting the blood pressure down to target.
Yes. Yeah, so I'm going to give you approval. Now.
Yes.
Good. So let's go back one slide very quickly and just say that, thank you. So guidelines, you know, are a relatively recent invention. They, in the 1960s, we didn't have guidelines. During the 60s and the 70s, we had a huge explosion of research with randomized controlled trials becoming the gold standard for treatment, meta-analysis, systematic reviews, and the first guideline that really dealt with cardiovascular disease was the first blood pressure guideline, the Joint National Committee guideline in 1976. And then after that, we had a huge proliferation. And if we go to the next slide, now guidelines are the routine of practice for all of us. Let's see if we could get to the next slide. Yeah, thank you. So they're part of the routine of practice these days, and they are useful. They do provide a structured assessment. Can we go back one slide? They do provide a structured assessment of the evidence, and they are helpful. They're especially helpful in an area like blood pressure, where you've got a common condition where it is expensive to either the individual and certainly to society, where the practice patterns vary. And I'm aware that they vary in India just as they do in our country. There is a huge variation in control rates, and where we have a sufficient body of high quality evidence. So blood pressure definitely meets those criteria, and it's a very good area for a guideline. In the US, we tend to follow rules, and because guidelines had been very problematic in the past, we now tend to follow the Institute of Medicine guideline rules, and I won't go through them in detail, but they are pretty rigorous. As I mentioned, the Joint National Committee really has been the one to do most of the guidelines until recently in the US, and that was funded by the National Institutes of Health. In the first guideline, in the 1970s, 77, it introduced the concept of step care. There were only 6 recommendations. They all dealt with diastolic blood pressure. And really, the only recommendation at that point was to treat anyone with an average diastolic of 105 or greater. And obviously, we can go on to the next slides. We have progressed pretty substantially since that time. I don't know if I can control this. Yeah, we've had many Joint National Committee reports. The last major comprehensive report in the US was the Joint National Committee report, the 7th one in 2003. And it was a lot more detailed, a lot more structured. It had introduced a focus on systolic blood pressure, a strong focus on dealing with the underlying problem with lifestyle modification, and many more recommendations, and recommendations for starting treatment and controlling treatment to levels of systolic less than 140, diastolic less than 90. And that has been the sort of cut point that most of us have been familiar with. There have been in the US several subsequent guidelines, but they've all been pretty narrowly defined, mostly focused on treatment issues. Now in 2013, the National Institutes of Health decided to stop producing guidelines in the US, and they handed that responsibility over to the American College of Cardiology and American Heart Association. They spent about a year putting together invitations to other professional societies to join them in a guideline around blood pressure. Had that done by 2014, and so they ended up with those 2 organizations being the lead, but 9 other organizations from a variety of areas joined them. They put together a writing committee. We had 21 members, multidisciplinary, a mix of cardiology, internal medicine, endocrinology, nephrology, geriatrics, We had pharmacists, nurses, nurse practitioners, and 2 lay patient participants. None of the members of the committee have any relationship or had any relationship, relevant relationship with commercial industry related to blood pressure. We had a separate committee, an independent external review committee, to whom we gave some questions, and they did a systematic review and meta-analysis for some of those questions. And the process was a very rigorous one. We followed the ACC-AHA task force guideline procedures, which are very well laid out and rigorous. We generated a document that is quite large because it's comprehensive. In the final written print version, it'll be about 110 pages. So it is long, but to try to deal with that, we broke it up into sections. There are 15 sections, and then in each of those sections, there are what we call evidence chunks. And within each of those chunks, we make recommendations. There are a total of 106 recommendations. They are supported by a lot of detailed evidence tables if somebody wants to look at them. There are 448 evidence tables. And each of those recommendations then is characterized by how important we think it is, the strength or the class of recommendation, and by the quality of the evidence surrounding it, the so-called level of evidence. There was extensive peer review, both internal and external. I went to about 48 reviewers around the world, a lot of reviewers internally identified by the 11 organizations, and then eventually was approved by the governing committees of each of those organizations. So it was a rigorous process. It took about 3 years to complete, and I hope that it is a thoughtful guideline. This is members of the writing committee. I won't go through it. I would just say they were all really, really focused and hardworking and a great group to work with, and they brought a really nice mix of expertise. Incidentally, Dr. Sheikh, I should mention that my vice chair, Dr. Bob Carey, who's a wonderful vice chair, is an endocrinologist, so endocrinology was well represented. Now, this is just quickly the class of recommendations and the level of evidence. The class of recommendations would go from 1, where we feel there's a very strong recommendation to follow that guide, all the way down to 3, where there's either no benefit or, in the worst case scenario, we believe there's harm. And then on the level of evidence, all the way from A, which would be the best evidence, down to CEO, which would be there's no good scientific evidence, and it's a consensus of expert opinion. Well, there's a lot in the guideline, and we don't have time to go through it today, but I want to just focus on a couple of areas that I think are important. So I'll focus on the classification system. We updated the classification system. It was last updated in the US in 1993, and we have changed the system. We have a lot of focus on blood pressure measurement, both in the office and out of the office. We introduced, at least for the US, new recommendations for how to approach thinking about clinical decision making. We introduced lower targets for blood pressure during treatment, and then we introduced a lot of strategies to improve control rates. So let me start with the classification system, and I'll say that normal blood pressure, as we've defined it, is exactly the same as it has traditionally been in the US. That is a systolic less than 120 and a diastolic less than 80. Throughout this guideline, we focused on systolic because almost all of the recent evidence suggests that systolic is much more important than diastolic in adults. And most of the recent trials and many of the observational studies have focused on systolic. However, at least for our physicians, they want to have recommendations around diastolic, and there is a large body of older evidence for diastolic. So with the exception of older adults where diastolic is typically low and systolic really is predominantly the important one, we have provided recommendations both for systolic and diastolic. But every time I talk about it, systolic is really where we have our greatest emphasis. So normal is the same as it was previously, and I'm showing the comparison here between our guideline classification and the Joint National Committee Recommendation 7 from 2003. We took what JNC had termed pre-hypertension, and we didn't like that term. It's hard to get the right term, but we worried that both clinicians and especially patients might believe that if they were pre-hypertensive, they didn't need to worry, that they didn't have hypertension yet. So we changed those terms, and for the bottom part of that classification, we took the 120, 129, diastolic still less than 80, and called that elevated blood pressure. And then for the upper part of pre-hypertension, 130, 139, 80, 89, we felt that should be called stage 1 hypertension. And that was an important decision. And the reason we called it stage 1 hypertension was twofold. First, at that level of blood pressure, adults already have double the risk for a heart attack and a stroke. So they're definitely at increased risk. And we now have a lot of non-pharm and drug treatment trials that suggest that getting to below those levels is beneficial. So that's why we changed that stage. Now, in our country, that does increase the number of hypertensives quite substantially. It increases it by about 14%. I can't say what it would do in India if you were to apply this classification, but here, about 14%. And it takes the overall prevalence from about 33% up to about 46%. So it has big implications. Then we said everything 140 and above systolic, 90 and above diastolic really ought to be called stage 2 hypertension, because at that level, people have very substantial increase in risk. So that's a big change. Now, I want to emphasize that in our recommendation is based on accurate measurement of blood pressure and use of averaging to get the average level of blood pressure. Now, we put a lot of emphasis on measurement of blood pressure, and sadly, around the world, including in the US, we know that blood pressures are not well measured in clinical practice. And we know that it's time-consuming, it's a pain in the neck, but we would close down laboratories that didn't measure cholesterol or lipids or other characteristics properly. We wouldn't fly in a plane where the pilot didn't take the proper precautions before flying. And we need to do a better job as a community in measurement of blood pressure. And we provided 6 fairly standard recommendations. They've been around for as long as I've been in the field of blood pressure. Prepare the patient properly, have them sitting, relaxed, with their feet on the ground in a chair with an upright back, avoiding caffeine exercise, emptying bladder, no talking during the rest period or the measurement. And then proper technique, use a validated device. We provide a URL to determine whether devices are validated. Take the pressure in the brachial arm, position the cuff properly, get the proper size of cuff. You can use either a stethoscope or a bell, and many meta-analyses that say it doesn't make a difference. And then, take the pressures in the arm that has the highest pressures, get several pressures, and get them on different occasions. And then important to average the reading. So we want to deal with predictable error, or so-called systematic error, and we also want to deal with random error, and we can deal with these quite satisfactorily. So those are simple recommendations. We all know them, but unfortunately, we're not all following them. So we did emphasize that, and we also emphasized the importance of getting blood pressures outside the office. If we've learned anything in the recent past, it's that office pressures are important. They are the basis for all of our clinical trials. However, they provide a very small window on what the body is exposed to. And we've learned, over recent years that pressures out of the office can also often be quite different to what we get in the office. So we recommended a strong emphasis on out-of-office blood pressures. It's best with ambulatory blood pressure monitoring, but in the US at least, that's not very commonly done. It's not something patients accept very well. It's done more often in Europe. So most of what we get is home blood pressure measurements. They're not as good as ABPM, but they are good. And the rationale for recommending them is first to confirm office pressures, particularly office hypertension. And obviously, if it's confirmed and the sustained hypertension, we're very confident of the diagnosis. But many times, 15 to 25% of times, people will have so-called white coat hypertension. They have high pressures in the office, but their pressures out of the office are in the normal range. And in almost all studies, those individuals have a risk of cardiovascular disease that is closer to normotensive than it is to hypertensive. So we don't have trials of treatment in that group, but we felt that that's a group where you probably didn't need to treat, but you definitely needed to follow them because some do go on to get sustained hypertension. And the even more concerning group is the group with masked hypertension. And again, it's quite common. 10 to 25% of patients will have a normal pressure in the office, but their pressures are high outside. And in almost all studies, that group tend to have risk characteristics that are closer to sustained hypertension than to normotension. And there are circumstances which might suggest white coat or suggest masked hypertension. We outlined those. And I won't go into detail, but the guideline has many algorithms like the one I'm showing on the screen right now that indicate when should you be concerned about white coat, when should you be particularly concerned about masked hypertension, and how would you follow an algorithm to ensure that you've identified that patient either has or doesn't have one of those entities and what to do. Now, the second big issue was our approach to treatment. And in the US, we have typically focused largely on treating based on average level of blood pressure. We felt, particularly in stage 1 hypertension, that it was very important to understand whether the patient was at high risk for cardiovascular disease or not. If you're treating to prevent events and somebody is at lower risk, it's unlikely your treatment can prevent the risk because they're not likely to have a complication. If, on the other hand, they're at high risk, you're very likely to have an event, and you're very likely to do the patient favor by treating them effectively. So we recommended healthy lifestyles or non-pharmacologic interventions, and most non-pharmacologic interventions have to do with lifestyle improvement. We concluded, not surprisingly, that about 90% of all high blood pressure really had to do with diet and physical activity. And so that's the underlying problem. And that's, of course, true for lipid problems just as it is for high blood pressure. And our big problem, and it's a problem really in many countries around the world, is that we live in a society where our diets are not very healthy and we're not active enough. That's the fundamental problem, and that's why the prevalence of high blood pressure is so high in our society and many others. So in stage 1, we definitely recommend non-pharmacologic interventions, but for the subset who are at high risk for cardiovascular disease, either because they've already had an event or on a risk calculator, they seem to be at high risk when you put the risk factors in. We picked a risk factor calculator that we thought was about the best that was out there. It is based on experience in many cohorts, and it is the one that is also recommended in the US for treating patients around lipid abnormalities and making decisions around aspirin treatment in primary prevention. So it was both convenient to our clinicians to say use the same risk calculator, and we thought at this time it's about the best one that's out there. But that, of course, could change. And based on that risk factor, if an adult had a risk of an event greater than 10% in the next 10 years, we characterize them at high risk. So had an event already or at high risk, we said you should not only treat with lifestyle, but also with antihypertensive medication. And that's in the US about a third, about 30% of all stage 1 hypertensive. So the vast majority of stage 1 hypertensives, we recommend lifestyle changes, but not drugs. So for a minority, antihypertensives as well. We recommend doing risk calculation in all hypertensives, but as a matter of practical convenience, we accept that almost all diabetics who are adult and have high blood pressure will be at high risk. The same is true for patients with chronic kidney disease. We recognize that adults who are over the age of 65 or older, are also almost uniformly at high risk. So as a matter of practical convenience, we said, we recommend using the risk calculator if you need to, but you know, you really don't need to. You can go ahead and treat with lifestyle and drug. And likewise, for stage 2 hypertension, we indicated that both a combination of non-pharm and drug was appropriate. We recommended getting to lower levels of blood pressure. For those who were being treated for hypertension, a systolic less than 130, a diastolic less than 80. For those older adults, 65 years or older, we focus entirely on systolic, so systolic less than 130. So those are about 10 millimeters lower than we've traditionally recommended in the US. Now, how do our guidelines for treatment goals shape up with the rest of the world? Well, the Canadian guidelines already recommended actually lower targets starting in 2016 for patients at high risk for treatment. They, of course, as we do, recommend shared decision-making and careful implementation and monitoring. The Australians made a similar recommendation in 2016. In the US, the American Diabetes Association made a recommendation that all diabetics, it's a very recent one, all diabetics should be less than 140/90. Diabetics at high risk should be less than 130/80. In my experience, an adult with diabetes and hypertension is almost always at high risk, so we're pretty consistent with that recommendation. And my hunch is that other guidelines will also target lower pressures during treatment. Let me just quickly say non-pharm treatments. We provide a lot of information, and on the American Heart website and the American College of Cardiology website, a lot more. But the 6 approaches that are best proven to be effective, at least in the US, are weight loss for those who are overweight, a healthy diet, and there are many healthy diets, heart-healthy diets. In this country, many people know the Mediterranean diet. There's one in particular, the dietary approach to stop hypertension, or DASH diet, that is particularly well suited to lowering blood pressure, reducing the intake of sodium, increasing the intake of potassium, much preferably by changing diet, physical activity, any form of physical activity, but particularly aerobic, the typical activity, walking, running, swimming, cycling, those sorts of activities. And moderation in alcohol intake. If we recommend it, if someone isn't drinking, don't start. If they are drinking, we know alcohol is a strong pressor, so 2 drinks or less in men, 1 drink or less in women. And we provide a lot of information around those recommendations. For drug treatment, excuse me, we started with the premise that one should determine if a patient has a compelling reason to use a blood pressure lowering medication for some other purpose. If they're post-MI, they need a beta blocker. If they have stable ischemic heart disease, they may need an ACE inhibitor. If they have heart failure, there are indications for particular drugs. So that should be the starting point. If there are no compelling indications, then we concluded that lowering blood pressure is the most important job, and there are many drugs that can do that. Our independent review committee suggested that long-acting diuretics are the best, and the one we use here is torthalidone. I'm aware that in other countries that is not always available, and indapamide is a good substitute. So they recommended that, but we felt based on the entire literature that either a diuretic, a calcium channel blocker, an ACE inhibitor, or an ARB would be acceptable as a first-line agent. Although in our country, diuretics and calcium channel blockers are probably the preferable agents in most patients. We also recognize that the vast majority of patients will require 2 drugs, and we recommended specifically in stage 2 hypertension, and in our country, in African Americans who have hypertension, that they definitely should be starting on 2 drugs at the outset. Lower dose, 2 drugs, less risk factor, and less side effect. And then building up, but again, the important thing is to get blood pressure control. We recommended a number of combinations that make sense, and we recommended avoidance of certain combinations, particularly combination of ACEs or an ACE and an ARB together. Those are definitely proved to be harmful. Well, when we look around the world and we say, how are we doing? We're not doing well. None of us are doing well. We did at Tulane our first global estimates in 2000, and we just updated those earlier this year for 2010. And we've improved a bit, but overall, even at the 140/90 cut point, we're only controlling about 14% of people. In countries that are lower or middle socioeconomic status, we're doing even less well, less than 8%. So we have a huge problem in awareness, treatment, but particularly in proper treatment and control rates. Now, can we do better than that? Absolutely. We know that in clinical trials, we do way better than that. And we know that in our country, progressively, we have done better. So in the US as a whole, we have doubled our control rates from the late 1980s through to the most recent national surveys. We do much better, as I mentioned, in clinical trials. We do much better in systems of care. All systems of care are doing a lot better in the US. My system of care is now over 80%. Some systems of care are reporting better than 90% control rates for the 140/90. So we know that with insured patients, with systems of care that take steps to improve control rates, they do better. And we borrowed in the guideline from a lot of the steps that they use to improve control rates. And the strategies that are well proven to improve control rates are focusing on adherence, having that as part of our discussion with patients to understand how well they're adhering to the treatment, because we know adherence is poor. Focusing on once daily dosing, and almost all of our drugs are available now once daily. Using combination pills where the combination is appropriate for the patient. Using strategies that promote lifestyle modification. Taking advantage of team-based care, and obviously that starts with a team of 2, the patient and the provider, but it can build to include other providers, other physicians, nurses, pharmacists, staff in the office and in the community, spouses, relative friends, and shared decision-making is an important way to improve control rates. Taking advantage of electronic medical records and medical registries. Electronic medical registries, to scan those registries, is a patient controlled? Is a patient showing up for their visits and tracking them down and doing a better job? Taking advantage of the many telehealth strategies that are out there for understanding what's happening outside the office. Using performance measures and quality improvements initiatives, and even financial incentives. They're not very powerful, but they can be useful. So a lot of strategies that we know improve control rates. So those are a number of the strategies. Now, The good news is we have some big initiatives in the US to try to improve control rates. The Million Heart is being funded by our CDC and the Centers for Medicare Services, and American Heart and American Medical Association doing something called Target BP globally. There are so-called Global Hearts. It's a spin-off of the Million Heart study. There is a new initiative that you may be familiar with called Resolve. It's well-funded, focused on improving blood pressure control, reducing sodium, and eliminating the use of trans fats. And there's a new initiative between the X Prize Foundation and American Heart. So I hope all of these will help us to achieve much better control rates. So briefly, guidelines are a part of the normal process. We introduced a guideline recently. It was designed for the US. Some elements will be very transferable to other countries, some elements not so transferable. It's long, but we've tried to write it so it's easy to navigate and hopefully helpful for clinicians and patients. And I've gone through just 5 of the selected highlights. And I thank you very much for allowing me to share the guideline with you today.
Yeah.
You're having a little problem out here. I'll just be with you. Yes.
Yeah.
Thank you very much, Dr. Paul. That was a wonderful session. We all over the world, and especially in India, we have a lot of hypertensives and a large number. There was a lot of worry that a lot of patients people suddenly became hypertensive. But I think it's a very important step, because I think if we put a patient as a hypertensive above 140, then people don't take the figure so seriously. Reducing that figure will, I think, allow us to lower the blood pressure in a far larger number of patients who need blood pressure control. So I'm very happy with the reduction of blood pressure limits and not calling these patients pre-hypertension and actually calling them hypertension. Because if we tell a patient, yes, you are a hypertensive, if you don't want to take medicines, do this, or you will really get into medicines, rather than saying pre-hypertension, as you mentioned, and patient thinks, oh, I don't have hypertension. So I think that's extremely important. Of course, we need to see how this is going to pan out in terms of how we will be able to achieve these target levels. I think I'm going to pass on to Dr. Sheikh and take her comments as an endocrinologist, and what do the ADA and other guidelines suggest as management of hypertension targets and guidelines. So, Shailin.
Thank you, sir. Sir, one thing which I really liked about these guidelines was the emphasis placed on measurement of blood pressure. I think we just are not very particular about measuring blood pressure. Everybody is in a busy consulting, not using the adequate precautions that you need to put in place to measure blood pressure. So I think that's the first most important message that this guideline puts across, that please measure blood pressure particularly. And the second important thing from the diabetic viewpoint, so we all know that almost 80 to 90% of diabetic patients are hypertensive. I think across the guidelines, there has been more or less a consensus that the blood pressure that we want to target in diabetic patients is less than 130/80. There was a little bit of a change of opinion saying that maybe it should be 140/90. But even the ADA criteria says that the blood pressure should definitely be less than 140/90. And if you can individualize targets and individually, without the risk of creating too many side effects and without increasing the treatment burden, bring it down to less than 130/80, that would actually be absolutely ideal. So as of now, I think there's a concern that more or less we need in our diabetics patient to have blood pressure less than 130/80.
Yes, well, if I could add one thing, we certainly increased the prevalence of hypertension quite substantially, and we were aware of that and were concerned about it. Would it overwhelm the system? Would it be rejected? On the other hand, by introducing, at least in the US, a new approach to treatment that would combine blood pressure level with an understanding of underlying cardiovascular risk, we don't change the number of adults who are recommended for use of medication very much. In fact, less than 2% in the US. I don't know. Again, these risk calculators are very country specific, and I'm aware that even for the US, many of the cohorts we're using were developed in Europe, some in the US. And then when you get to other countries, those risk calculators may not be as useful as they are in the US. But recognizing that, we increased the prevalence a lot, and we felt that was appropriate because people are at high risk and they do benefit from lower pressures. And on the other hand, we were pretty careful about the recommendation for adding antihypertensive medication. So it doesn't change very much percent that should get a drug in this country. It does mean, as Dr. Sheikh said, we need to be more careful about understanding who has hypertension and who gets what form of treatment.
You may remember about a decade ago, BMJ published a very nice article where they secretly monitored doctors taking blood pressure, and they found how horrible doctors were at monitoring blood pressure or measuring blood pressure. So I think we need to secretly record people measuring blood pressure and make sure that the blood pressure measurements are done correctly. But I think the most important aspect of it is correct blood pressure measurement. So I think we need to train everybody to do correct blood pressure monitoring as the first step.
I agree. We had, sadly, we had a recent survey in the US of medical students and how they are taught, and only 1% of them were thought adequately to take a blood pressure. And unfortunately, we put many questions on boards. We put a lot of emphasis on many things in our training and in our exams, but what you will never find on a board is any questions around the measurement of blood pressure. And that's a shame because it's such a common requirement in clinical practice. So hopefully we can do some good. And the other area that I think is a big challenge for all of us in practice is how to manage lifestyle, how to improve lifestyle. It's a big challenge for researchers. It's a bigger challenge for clinicians. And I hope we can't avoid saying that that's the underlying problem and we need to deal with it. And we made a lot of recommendations. And of course, some patients do very, very well, some not so well. We hope that we can open up a new discussion and try to help our populations to become healthier, because fundamentally, that's underlying our problem. Our problem in the US, like many countries, is we have an unhealthy environment for blood pressure, for lipids, and we've got to tackle that. Very big challenge.
The primary question that many doctors are asking is about the elderly hypertension. That seems to be always a concern, the elderly and bringing the blood pressure so much down. What are your thoughts about that? What do we need to be more careful about in the elderly when we bring blood pressure down to these targets?
Well, let's start with older patients. And now here in this country, I used to say elderly, and our American Geriatrics Association won't accept papers anymore where we're using that term. So it's now fashionable in the US to say older adults. I'm sure this fashion will change over time. But let's start with the premise that what do we want to do in older adults and how can we help them? We want to keep them healthy. We want to keep them out of hospitals and out of nursing homes. They want to do the things they enjoy doing. They want to get to the weddings, to the graduation of their grandchildren, and so on. And they're on a slight decline. We all know that. Sooner or later, all of us are going to die. And what we want to do is flatten that as best as we can. There are not too many interventions that we can undertake that help us there. And one that is well proven to be helpful is lowering blood pressure. So we start with the premise that this is one of the interventions that is exceedingly well shown to be beneficial. And SPRINT and HIVET have both shown that even in very old patients, they do well. Now in sprint, almost a third of our participants were 75 years or older at entry. They had very high risk for events. They did relatively as well as anybody else. In absolute terms, they did much better because they had a much greater risk of an event. And even within that group of older patients in sprint, when we looked at those who were most frail with an indicator of frailness or with a walking test, and all of us know for our patients, we can do a simple walking test. Somebody who walks slowly and poorly is at very high risk. It's a great functional test. For those who had slow gait speed, they had very high risk of events, but one thing that helped them a lot was lowering their pressure. So we know the intervention works. Now, does it have risk? Well, yes, it does, but actually a lot less risk than people think. And although I would be the first to say we need to be careful when we're treating, especially in older adults, we need to be more cautious in the introduction of therapy, careful in the monitoring of therapy. We shouldn't be paralyzed by the fear of a side effect to stop us to doing something that is helpful for older adults. So I'm talking now about older adults who are functional, who are free living, otherwise reasonably well. For somebody who is in a nursing home or is in the hospital and has a lot of comorbidity, that has to be a shared decision between the clinician and the patient. It depends a lot on their life expectancy. It depends a lot on their quality of life, how many medications they're taking. That has to be a very individualized decision. But I think for free living, relatively healthy older adults, which is the vast majority of older adults, this is one area where we can really help them a lot. So that was our feeling, and it's a feeling shared by the Canadians and Australians that therapy is very helpful. It needs to be conducted carefully, of course, and it needs to be monitored carefully. Now, when we looked in sprint, for example, what did we see as risk factors or side effects? Well, two things that you see in all of these intensive lowering trials is you are going to see electrolyte changes. Not common, but it's going to be more common. And that's expected because you're using more drug. And it's going to be hypokalemia, hyperkalemia, hyponatremia. Those are the common ones. But they're still not very common. We need to monitor for them. You see a slight bump in estimated glomerular filtration rate. It's not big. In sprint, it was a change of about 3 mils per minute. So it's not huge. We don't see in any of these trials a doubling of a halving of estimated GFR or end-stage renal disease. And that change in the eGFR seems to be a hemodynamic effect of more drug and the type of drug. And it seems to resolve when you moderate or stop those drugs. So those are the common ones that we see. Now, other than that, are there serious side effects? Very uncertain. We monitored for a number of things in sprint. A number of patients had what we call serious adverse events, but essentially what that was hospitalization. And it was an unblinded trial. So we don't know what it means. We have published or are about to publish on a follow-up of those patients, and it seems that they didn't really have much to concern us. So I don't want to underplay it, but I would say I think in the literature, the concern about side effects has been played up a lot, and we need to balance that with the understanding of benefit. And of course, always be careful in treating and monitoring.
Yes, thank you. I usually tell doctors who inquire about this that they must treat very elderly patients also and bring their blood pressure down. They should take 3 precautions. One is bring it down a little slower than they would in a younger patient. Watch for postural hypertension, especially if it is symptomatic, and look at renal function and electrolytes at more regular intervals. but
Right.
don't not bring down the blood pressure thinking it's going to be harmful. So I think that sort of is very important to pass on to the younger doctors. Question I have from here. Yeah.
I was going to say that is absolutely, in my mind, the perfect advice.
There's a question here about renal patients, those who have CKD of varying degrees, those who are on dialysis, not on dialysis. How do you judge and treat their targets?
Well, certainly for those with renal disease, we know they're at very high risk for cardiovascular events. I'm a nephrologist by background. What do renal disease patients die from? They don't usually die from renal disease. They die from cardiovascular complications. So in all of these trials, including SPRINT, we have not proven a benefit in slowing renal disease. And perhaps that's because we would need to have longer trials to do that. We're continuing to monitor in SPRINT for dementia and cognitive impairment, as well as renal function, and those probably take a longer time than typical atherosclerotic events. But we do know that they're at high risk for cardiovascular events, and those can be prevented. So I think for most patients with chronic kidney disease, there is good indication. Again, in SPRINT, about a third of our patients had underlying chronic kidney disease. Now, we don't have that much experience when you get into very advanced kidney disease, and we don't have any clinical trial experience in blood pressure lowering in patients on dialysis. So there it really comes down to expert opinion. But when we get to the majority of patients who have chronic kidney disease, down to, say, an eGFR of 30 and above, we have good evidence that treatment is beneficial. Again, needs to be done carefully.
Dr. Sheikh, in your practice in India, when you see these diabetologists, how do you handle them? Do you sort of very aggressive with their BP monitoring, and how do patients respond with those who are diabetics particularly?
So in diabetic patients, we are very aggressive with BP reduction, because we have enough data which shows that in diabetic patients there's more benefit as far as BP reduction is concerned. 1A, because diabetes, as we know, even if I look at the atherosclerotic cardiovascular risk score, we are already at a risk of more than 10% simply by the fact that you are a diabetic. So any good control of blood pressure will reduce both macrovascular complications like cardiovascular disease, heart failure, as well as there is also improvement as far as microvascular complications are concerned, like nephropathy. So definitely I think we need to be very aggressive as far as BP reduction is concerned. There's this mindset. The only thing which we emphasize all the time is that in diabetics, preferably we would prefer using an ARB or an ACE inhibitor at diagnosis of hypertension in our patients. That would be the first drug of choice, and then you can add whatever you want subsequently depending on the blood pressure.
Thank you. Dr. Paul, there are a lot of questions here about which drug would you use? Does it really matter what drug you use? People are asking, should we use olmesartan, telmisartan, azilsartan? So, does it really matter the drug of choice in terms of benefits?
Yes. So we concluded to start with, was there a compelling indication for using some blood pressure lowering medication for another reason? Be it a diabetic, and we, Dr. Shah, were a little more, perhaps, what should I say, restricted. We felt in diabetics with proteinuria, especially heavy proteinuria, there's a very strong case for using ACE inhibitors, and if they're not tolerated, an ARB. All others, we were very comfortable with using other drugs as well. But starting with the premise, is there an underlying, usually it's a comorbidity. Do they have stable ischemic heart disease? Immediate ACE. Do they have heart failure? Do they have diabetes? So that was a starting point. If they had no compelling indication, our independent review committee, based on their meta-analysis, suggested to us a long-acting diuretic is the best. And it beats everything in terms of prevention of heart failure. We know that. But generally speaking, when you look at most meta-analysis, most of these drugs they'll have a slight benefit here, not so good there. Across the board, most of the drugs are about the same. And what becomes apparent from the overall experience of meta-analysis is that lowering blood pressure is the important issue. So we suggested you could use any of 4 classes that are well proven to be beneficial: long-acting diuretic, calcium channel blocker, an ACE inhibitor, or an ARB. In the US, we know that diuretics and calcium channel blockers are generally preferred. If you want to lower blood pressure, they'll do a little better than the other agents, especially as you get to older patients and especially dealing with African Americans. In younger people and in whites, ACEs are probably preferred. ARBs are a little less well proven. There's just not as many trials, and they're harder to do the trials now because of co-treatment. But all of those classes seem to work well. And the other thing we concluded is that most patients need 2 drugs. So it doesn't matter. In most patients, especially if somebody is at higher pressure, stage 2, or in our country, they're African Americans, we definitely felt the evidence was very strong that you should start with 2 drugs at lower doses. And the important thing with whether it's 1 drug or it's 2 drugs is to achieve blood pressure control. The only combinations that we recommended against, and very strongly against, is duplicate ACEs or the combination of ACE and ARB. We know that those are proven to be harmful and should not be a part of combinations. Other than that, getting the blood pressure down, it was for us the key issue.
Dr. Sheikh, do you have any questions specifically for Dr. Paul?
No, sir, I'm good.
Good. Okay. Then I would like to ask about the BP machine. In India, we still use mercury machines. People often in India feel that digital is not correct somehow, and they always sort of feel that the mercury is correct. Do you suggest any particular brand of machine? Because I mean, there's hundreds of machines, and I mean, if the most important thing is the BP value, and if the machines are not correct, then how do we come to any conclusion?
Well, we, like others, spent a lot of time worrying about this, thinking about this. I'm old-fashioned, and you can see I'm older. I have high blood pressure. It's one of the things I have. I take my pressures at home. I use a mercury sphygmomanometer. The mercury sphygm is a very, if done properly, gives you a very accurate reading of blood pressure. However, it's becoming increasingly less available in many countries. Mercury is banned in most European countries. In the US, the Veterans Administration doesn't allow the use of mercury, and I think we're seeing a gradual phasing out of the traditional mercury sphygm. Aneroid sphygmomanometers, when they come out of the factory, are great, but they are very prone to damage. There is a little filter, and if the aneroid is dropped on the ground or otherwise hit against the side of the examining table, it's damaged very easily. And it's notorious that aneroid sphygmomanometers tend very quickly to give you very poor quality readings. And it's notorious that there is not good follow-up to determine their accuracy. So that gets us to oscillometric measurements, which is increasingly the common measurement in the US and most European countries. And we looked at those. There have been a lot of validation approaches. They're not perfect. The oscillometric device does not measure blood pressure in the same way the auscultatory approach does. It looks at oscillations of the vessel wall, and then it uses statistical algorithm to estimate systolic and diastolic. Now, the unfortunate thing is these are all commercial. The companies don't disclose their algorithms, so you don't know exactly what they're basing the pressures on. But you can reasonably presume that they're basing it on several cycles of blood pressure. So they have been tested against mercury, and there are many of them that seem to be quite acceptable. There are a number of URLs. We provided a URL. The best one is actually the one that's produced by Owen O'Brien in Ireland and the British Hypertension Society. But we're trying as a world community to come together to get a common URL. We provided that URL. We determined that there were many very good measurement techniques at the wrist, but we worry that people who take wrist measurements will not have their wrist at heart level. So we continue to recommend brachial measurements and the use of validated devices, and we provide a URL. Many of the common devices that are sold in the US at drugstores are quite valid. There are many invalid devices that are sold, particularly in other countries. I'm very familiar with what is being sold in China and in Taiwan and other Asian countries. There are tons of approaches now, and we're going to see a big change, I'm sure, over the next 10 years or 20 years. When I go to Asia, many of my friends wear watches that are reputed to give them ECG tracings, blood pressure, pulse, mood swings, etc. Many of them are very invalid, and we need to be careful. There are many apps, as you're probably familiar with now, on iPhones that use the camera to try to get photoelectric measurements of blood pressure. They're almost all very invalid. So for now, we concluded that brachial measurements using any device that is valid, including oscillometric, were acceptable. But the important thing is to follow the simple steps for trying to ensure accuracy of the measurement.
We all know that it's easy to measure the systolic blood pressure, but when it comes to diastolic blood pressure, it's fine with young people. When we get to the elderly, diastolics begin to drop quite a bit. So
Right.
Where do you put your diastolic value? Suppose you have an elderly patient whose blood pressure is 150, you want to bring it down to 130, which is your target, and his diastolic is dropping to 60, 50. You just ignore the diastolic. I've heard some BP specialists saying, don't even talk about diastolic in elderly. And some say, no, if you bring it 2 down, they'll land up with an infarct. So where does diastolic blood pressure stand?
Well, throughout our guideline, we recognize that most of the relevant information that was the basis for our recommendations was based on systolic. And particularly as we got into older ages, you're correct, diastolic tends to go down. Systolic becomes an increasingly important predictor of risk. Now, we looked at that issue in SPRINT. We know if you take blood pressures on people who are being treated and analyze them observationally, what you'll see is a J-shaped curve. Those at very low pressures tend to have high risk. And that has been a concern. And what does it mean? Does it mean that we should not treat to low pressures? Most of those J-shaped curves have been related to diastolic, and they've been reported particularly in patients with underlying coronary disease. And the question has been, is it important? Well, one of the things we're able to do in SPRINT is analyze it using a randomized approach, because what you really want is not an observational estimate, because I can tell you as an epidemiologist, we see J curves all the time. So an observational J curve in a group being treated doesn't surprise me. Those who are at risk for events can't mount a blood pressure, so they're likely to have low blood pressure. So it's really hard to tell what's the horse and what's the cart in that situation. The only way you can get at it is using randomized comparisons. And in SPRINT, what we saw is observational analysis showed us a J-shaped curve, but all the way down that curve, even into the lower end of the hook of the J, when we looked at a randomized comparison, lower systolics tended to be better. I could tell you when we were doing that trial, our Data and Safety Monitoring Board was often concerned and came back to us and said, we're concerned when we look at the data that you have a lot of people who are at very low diastolic blood pressure. And are you sure they're okay? And what are you doing to ensure the safety of the treatment? And we did have a lot of people at low pressure. And I think it would come back to saying this is why we have clinicians. We need to make good clinical judgments. And as you said before, Dr. Dalal, an important part of this is understanding whether somebody has hypertension, including postural hypertension. Are they symptomatic? The body is giving you a very good signal. For many people, they tolerate very low diastolic blood pressure. So I think in general, we still feel lowering high systolics is beneficial in the context of low diastolic, but it needs to be done carefully, and we need to follow for symptomatic evidence of hypertension and measure blood pressures both sitting and standing in our offices.
I think the topic has been so interesting that we've actually overshot our 1 hour times, but I'll take one more question if it's okay with you. One last short question. How do you deal with patients with stroke? For example, suppose somebody's had a stroke, or I'm asking this from my own point. Suppose somebody's got a 90% lesion in his carotid artery, and I want to treat his blood pressure. Is it safe in that patient to also bring the blood pressure down, or would I change my therapy?
We have a lot of recommendations in our guideline around various aspects of cerebrovascular disease. I would say at the present time, our group, working with colleagues in China, have done the largest of the immediate post-stroke blood pressure lowering interventions. It appeared in that study, it didn't do any harm, but it didn't do any good in the short term. We're going back in another big study now to look at a slightly different protocol. In treatment of stable post-ischemic patients who are hypertensive, we don't have definitive evidence yet, and there is a big trial that is going to get underway in China very soon. Our general instincts would tell us that patients who are at high risk, as these sorts of patients tend to be, are likely to benefit from lower pressure. But it would be nice to have definitive trials in post-stroke stable patients with high blood pressure, just as it would in diabetics with high blood pressure, to get definitive evidence of proof. We don't have that now. We know in the pre-diabetics and sprint, they seem to do as well as everybody else, but and when we pool trials like Accord and Sprint, they seem to give us similar results. But it would be helpful for all of us to have specific trials in diabetics and in stable post-stroke victims who have high blood pressure.
Dr. Sheikh, any last comments before I say thanks to everybody? Any last comments from your side, or any last thought processes?
Sir, I think that we really need to emphasize more and more on blood pressure monitoring. Initially, monitoring, teaching our students as well as colleagues how to measure blood pressure more efficiently. And then I think there's a lot of physician inertia as far as treatment is concerned, sir. A lot of family physicians, a lot of doctors feel if it's a blood pressure 140/90, that's absolutely okay. There's no big deal to it. So I think that mindset needs to change. And I think this is the first step in that direction, to be able to change that mindset that no, it's not okay to have a blood pressure 140/90. We need to lower it. I think that's the most important message we need to give across.
Thank you. For me, I just want to say what a great pleasure it has been interchanging with both of you and with our audience today. And thank you for the privilege of joining.
Thank you.
So before we end, I would like to thank McLeod's for the educational support, their ProCare division. I would like to thank DocMode for always being there for updating. Dr. Sheikh, thank you very much for your participation. And Dr. Paul, of course, excellent presentation. We learned so much. And of course, all the 3 years of work you put into this, you had to tell us in an hour's time. So that's very difficult indeed. I'm sure all the doctors who logged in, and I think thousands of them have logged in, I really couldn't even take all the questions that they sent in. And I selected a few which I thought were most appropriate. So thank you very much, Dr. Paul, for spending your time with us and educating so many of us in India. And I'd like to end by saying what Dr. Sheikh said: stop this medical inertia. Treat blood pressure properly. Do not accept blood pressure till it reaches the target level as suggested by the 2017 guidelines. I think if we can simply do that, we would save so many lives, so many strokes, so many heart attacks. So I think we take home message is very clear. And once again, Dr. Paul, thank you so very much for your kind education of all the doctors, and thanks to all the doctors who participated. Thank you very much. We'll end this session.
Thank you, Dr. Paul. Thank you, sir.
Thank you very, very much.
Pleasure.
Interesting.